Good morning, everybody. My name is Tim Lynch. You're very much welcome to the latest IEHG Grand Rounds, which are monthly Grand Rounds across the group, but also beyond that across Ireland. Some of these sessions have been excellent today. We've, I think, a superb Grand Rounds today about VTE. I'm going to pass you over to Tomas, President, to go from there.
So welcome, everybody. Great pleasure for me to introduce the speakers and to introduce this topic. I know most of the speakers here as contributors and founders and presenters of the annual VTE meeting, international meeting that we run from the Pillar Centre every year. And we have some great international collaborations. So it's a fantastic team that are trying to drive forward quality patient care in terms of prevention of VTE and state-of-the-art treatment of VTE to basically reduce morbidity and mortality and deaths from VTE. So without further ado, I'll hand you over to Dr. Barry Kevane, our consultant colleague in the matter. Barry's a consultant haematologist in the Mater and Ireland East Hospital Group, graduated from UCC in 2008 and subsequently undertook specialty training in haematology and obtained a PhD in thrombosis and hemostasis. And he has been chair of the IEHG VTE working group since October 2019. And I know he does a lot of good work here in the matter in terms of hospital-acquired thrombosis, which is a very important topic which we will talk about. So over to you, Barry. Thank you.
Good morning, everyone. And on behalf of my co-presenters, I'd like to thank Dr. Breslin, Dr. O'Hanlon, and Professor Lynch for the very kind invitation to present today on the very important but yet frequently underestimated topic of venous thromboembolism. So over the next hour or so, we will discuss the morbidity and mortality risk associated with VTE, both globally and here in Ireland. We will present two cases illustrating the importance of having a collaborative, multidisciplinary approach in the management of all forms of complex thrombosis. We will discuss some of the work which is currently being undertaken by the Ireland East Hospital Group VTE Committee. And we are also delighted this morning to be joined by Ms. Anne-Marie O'Neill, who is the founder and CEO of the patient organisation Thrombosis Ireland. And Anne-Marie will bring the presentation to a close with some reflections on the patient perspective and on patient priorities for the future of VTE care here in Ireland. So I'm sure that many of you are already aware that venous thromboembolism, which consists primarily of deep vein thrombosis and pulmonary embolism, represents a major global health burden. It's estimated that about 1 in 1,000 people will experience VTE each year, and that about 1 in 20 people will experience some form of thrombosis over the course of their lifetime. And despite diagnostic and therapeutic advances, VTE remains the third leading cause of cardiovascular mortality worldwide after MI and stroke, and causes more deaths each year than breast cancer, prostate cancer, road traffic accidents, and HIV-related illnesses combined. In addition, we are increasingly becoming aware of the burden of chronic morbidity among survivors of VTE. Up to half of patients who experience deep vein thrombosis develop post-thrombotic complications in the affected limb, which can have major implications for quality of life and for the ability to return to work and normal daily activities. Similarly, it is also now recognized that as many as 50% of patients who experience acute pulmonary embolism continue to have significant cardiorespiratory symptoms months and even years after their diagnosis, with a small but very significant proportion of patients developing potentially life-threatening chronic pulmonary vascular disease. The optimal approach to preventing chronic morbidity associated with VTE remains to be determined, but it's worth noting that in Europe, it's estimated that VTE and its complications accounts for over 13 billion euro in health expenditure annually. Even more alarming, of course, are the data describing mortality rates associated with acute VTE. And while we have seen some improvements in survival rates with improved diagnostic and therapeutic advances, in the United States alone, it's estimated that up to 100,000 PE-related deaths occur annually. Unfortunately, we don't have accurate data for VTE-related mortality here in Ireland as of yet. But we do know that certain patient subgroups are at particularly high risk of VTE and of VTE-related mortality. Up to 20% of all VTE events occur among patients with cancer, and about 20% of cancer patients who experience a VTE will have a recurrence within 12 months despite anticoagulation. And the case fatality rate for recurrent thrombosis among patients with cancer may be as high as 15%. And in fact, VTE is now recognized as being the second leading cause of death among patients with cancer, second only to progression of cancer itself. We also know that the risk of VTE and arterial thrombosis is significantly increased during pregnancy, and that despite advances in VTE prevention strategies, thrombosis remains the leading cause of direct maternal death in the developed world. Something which is perhaps less well appreciated is the risk of VTE associated with admission to hospital. Patients who are admitted to hospital often have pre-existing risk factors which predispose them to thrombosis, such as underlying cancer, pregnancy, active infection or inflammatory disorders. And then these patients are often then exposed to additional risk factors during their hospital stay, such as immobility, surgery, etc. And so it shouldn't come as a surprise to anyone that the majority of all VTE events occur either during hospital admission or in the 90 days following discharge. And the burden of this problem is so significant that hospital-acquired VTE is now recognized as being the leading cause of potentially preventable death associated with hospital admission. And it's very important to highlight this point that these VTE events are potentially preventable. And this is something that we have seen consistently from high quality clinical trials, where a targeted approach to the use of pharmacological thromboprophylaxis in high-risk patient subgroups guided by formal VTE risk assessment has been shown to be potentially life-saving. And this is something that we've seen probably most clearly in UK data, where a system of mandatory individualized VTE risk assessment for all patients admitted to hospital, followed by the targeted use of pharmacological thromboprophylaxis for patients who are identified as being at high risk, has been shown to not only reduce the rate of hospital-acquired VTE, but also to prevent VTE-related mortality. And on foot of data such as this, we have seen in Ireland a move towards the introduction of formal VTE risk assessment policies and prophylaxis guidelines in our hospitals, as illustrated in these slides here from St. Vincent's, courtesy of Dr. Murphy and Niamh Hanlon. But across the country, the introduction of these types of policies occurs somewhat on an ad hoc basis. But we are delighted that we will be joined this morning for our panel discussion by Ciara Kirk, who is the clinical lead for the HSE National Medication Safety Programme. And Ciara, along with Dr. Philip Crowley and colleagues in the HSE QI division, were instrumental in bringing attention to hospital-acquired VTE risk at a national level through this HSE Improvement Collaborative Project, which showed what could be achieved in terms of the appropriate use of thromboprophylaxis when a systematic approach to VTE prevention is adopted in our hospitals. This report from the collaborative put forward a number of key recommendations, which I think are centred on the requirement that all patients admitted to hospital are formally risk assessed within 24 hours, and that we maintain a constant process of rolling audit to ensure that we meet this crucial patient safety goal. On foot of this work, we have also seen the introduction of a new HSE KPI for suspected hospital-acquired VTE. This was a landmark development which not only demonstrates the commitment of the HSE to prioritising VTE prevention in our hospitals, but also puts responsibility on us as healthcare providers to be aware and conscious of VTE risk and take the appropriate steps to address this for our patients. Management of all aspects of thrombosis, both arterial and venous, is becoming increasingly complicated, particularly with the advent of novel therapeutic approaches and the increased recognition of the chronic complications of VTE. And so with that in mind, I'm delighted now to introduce our next speaker, who will present two cases which really exemplify the complexity of modern thrombosis care and which demonstrate the importance of an MDT and collaborative approach to treatment. So Dr. Karen Murphy is a graduate of University College Cork and is Associate Professor of Haematology at St. Vincent's Hospital and UCD, and she's been head of the Haematology Department in St. Vincent's since 2012. Dr. Murphy has a subspecialty interest in thrombosis and hemostasis and is a member of the R&D VTE Committee. She runs a high-risk haematology clinic in the National Maternity Hospital in conjunction with maternal medicine colleagues, and she's also the newly appointed lead for thrombosis and hemostasis in St. Vincent's Hospital. So thank you, Dr. Murphy.
Thank you, Barry. Good morning, everybody. Myself and John have the pleasure this morning of presenting two clinical cases. Both cases happen to be maternal medicine cases. not specifically chosen for that reason, but more to underpin the complexity of some of these cases. And also, as Barry has already pointed out, the vital MDT involvement, where every member of the team brings their subspecialty expertise and perspective on a complex case. Barry has already alluded to the fact that despite major advancements in our antenatal and postnatal thromboprophylaxis piece, that thrombosis continues to be a leading cause of direct maternal death and indeed severe maternal morbidity. This slide from Anne Flem Jackson, a Norwegian colleague, shows the relative risk peak of thrombosis in the postnatal period, but really thrombosis can occur at any time, with up to 50% of thrombosis in pregnancy occurring in the first 20 weeks. So to move to case one is a 31-year-old female who has had an IVF cycle with embryo transfer and collapses at home 5 days later. She's brought by ambulance to Vincent's with left-sided limb weakness and ipsilateral facial droop, but has a positive beta HCG, so she's not given TPA and ED. She's transferred very swiftly to Beaumont, where she has a confirmed acute infarct in her right MCA. She had bilateral Dopplers of her lower limbs with no identifiable DVT, but both ovaries are noted to be markedly enlarged on an ultrasound of pelvis, and she has ascites. And this is in keeping with ovarian hyperstimulation syndrome, which is simplistically a supraphysiological response to ovarian stimulation. She has a mechanical thrombectomy and thrombolysis in Beaumont, does really well, is discharged relatively swiftly, and is seen very swiftly in the maternal medicine clinic in the National Maternity Hospital post-discharge. When we see her, she has done really well. She has confirmed viable pregnancy with size equal to dates of circa 7 weeks gestation. She's left with some difficult insomnia, but has made a full motor recovery. She's been discharged on aspirin and therapeutic twice daily low molecular weight heparin. She's seen very regularly in the immediate aftermath of discharge and is, when we consider her stable, switched to once daily dosing regimen. She gave herself and ourselves a bit of a fright one day when she decided to have a significant vasovagal in a busy outpatients and had a significant head injury, and clearly was on therapeutic low molecular weight heparin, had to be transferred back to Beaumont, but thankfully her CT showed no sequelae and they managed to suture what was not an insignificant laceration under local anaesthetic. This is her management plan for delivery, and any patient on full dose anticoagulation has a multidisciplinary team management plan with input from haematology, from my maternal medicine colleagues, and from anaesthetics. And you can see that we try as best possible to mitigate for all circumstances that might occur. So as with many of our cases on full dose anticoagulation, the plan was to see her weekly from 36 weeks, and then to consider her for induction and possibly dose reduction of low molecular weight heparin. Remember, she'd been on it since very early in pregnancy. She complicated things a little bit by developing something called gestational thrombocytopenia close to term, but thankfully her platelet count never dropped below 100, so it didn't complicate our medical management. So despite our lovely management plan, the baby, like all good children, decided to ignore it and come early. Thankfully, however, all our women are told to take their heparin in the morning, and she was nearly 24 hours post her therapeutic low molecular heparin when she presented. She had delivered a lovely, healthy baby boy, had minimal bleeding, and managed to have epidural anesthesia. And now mum and now toddler are doing really well. Case 2 is also a maternal medicine case. She presents again in her first pregnancy, early in gestation, with a right lower limb extensive VTE. The vascular team were quite concerned about the leg of presentation. So there was an MDT discussion between my AMU colleagues, my respiratory colleagues, haematology, her primary obstetrician, and the vascular surgeons. We decided to treat her with therapeutic low molecular weight heparin twice daily and observe. But really, unlike many cases, there was no improvement over a number of days, and she had very limited mobility. An MRV confirms extensive right lower limb VT with extension into the infrarenal IVC. And again, in the coming 48 to 72 hours, there was little improvement in that leg. She was transferred to the Mater, where she had a mechanical thrombectomy under the expert care of John Moriarty, who's going to follow, and then transferred back very swiftly to Vincent's. She had a marked improvement, and in fact, despite the lead-in with no improvement, she was discharged within 48 hours of her mechanical thrombectomy on therapeutic low molecular weight heparin at BD dosing. And you can see from the timelines, she did so well. She didn't understand why she needed to come back to the maternal medicine clinic for all her appointments between the 4th of December and the 2nd of February. So with that, I'm going to hand over to John Moriarty. And while many of you will know John, John is a vascular and interventional radiologist and associate professor in the matter from UCD. He's a fellow of the Society of Interventional Radiology and Vascular Medicine. He's given over 200 invited lectures nationally and internationally, and is participating in many ongoing trials, and has very recently been elected as Vice President of the International PERT Consortium. So John, you have a lot to live up to, and I'll hand over to you.
Well, thanks a lot, and it's an honor to be here. It's a great panel, and I think it really highlights the multidisciplinary nature of VTE care, whether it's in DVT, right heart thrombus, or PE. And my little part of this panel and this particular patient became involved following identification of her large volume lower extremity and iliocaval thrombus. And to kind of orientate you, this is her initial presenting ultrasound. The image shows a large expansile acute thrombus within the femoral veins. And we describe these as being distal or proximal veins being the large caliber veins coming up from the common femoral up through the iliacs. And we know that they portend a worse outcome as regards the long-term problems of DVT, particularly post-thrombotic syndrome. So during this patient's time in St. Vincent, she went on to have an MR venogram. We would typically do a CT or an MR venogram in these patients to outrule a central lesion. That means either a clot or a stenosis, compression of the veins. And obviously, given her pregnancy, an MR venogram was done here. And for those of you who aren't used to looking at these, what we can see here in the video and then in the still panels are that on the left side, there's a widely open venous system. You can see the bright kind of flavoids within the veins. And then on the right side, there's occlusion because there's occlusive thrombus. And this extends all the way up to her renal IVC. And so this is a large volume thrombus. So as Dr. Murphy was describing, we had a long discussion about this. And one of the things about a lot of the real life patients that we're going to be seeing, that you're going to be seeing in your practice, particularly say with maternal patients, is that they fall outside of the established trials. And so you're kind of extrapolating what you believe to be the case from the evidence that applies to other patients, to the patient that you see in front of you, and then hoping for the best outcome. And certainly being part of a team when making those sort of decisions can be very gratifying for yourself and also give you the backup of multidisciplinary input. So what we elected to do was to do an aspiration thrombectomy. And we, because of her pregnancy, tried to do this with minimal contrast and minimal radiation. And the good news is that we now have a lot of techniques for doing this. And so this is a thing called intravascular ultrasound. And this is where we put the ultrasound cannula directly into the blood vessel. And we're able to see these large clots coming all the way through the iliocaval venous system. And then we go about removing it. And there's a ton of new devices for this. I'm just going to highlight the one that we used specific to this patient. The good news is there are tips and tricks and devices that can be applied to many different scenarios. And here we used one which directly removes the clot. It can be used without giving any lytics. Obviously, in someone who's pregnant, we want to avoid TPA as much as possible. And here you can see us removing this, the blood clot here, using this device called the Clot Retriever. And then we're able to remove large volumes of thrombus. And here you can see these large formed casts of the iliac veins and IVC. And the good news is when you remove thrombus from acutely thrombosed veins like this, you will frequently get a restoration of flow almost immediately. And the patients tend to have a very fast response. And that's gratifying. It means they can mobilize quickly. Their leg swelling goes acutely down. And then we believe this also portends a good long-term outcome so that their post-thrombotic syndrome risk, in other words, their chance of having leg swelling, discomfort, diminished exercise tolerance, and eventually varicose veins with ulceration is lower from having done this in their iliac and caval venous system. This was a good result for this patient, and then she was discharged back from the matter and our team there back to Dr. Murphy's expert care, and we'll be following up with her after her pregnancy to reevaluate her.
Thanks very much for that, John. So I guess ensuring that all patients can benefit from high quality thrombosis care, such as that described in these case presentations by Dr. Murphy and Dr. Moriarty, was one of the key motivations for establishing a group level VTE committee within the Ireland East Hospital Group. So this committee was established in 2017 by my colleague, Professor Fionnuala Ní Aonla, and we were the first hospital group in Ireland to prioritise VTE in this manner. So through the support of all our hospitals and of course the Ireland East Hospital Group executive, a number of key milestones have been achieved in the intervening years. These include the development of a group level VTE data dashboard, the first of its kind in Ireland, group level clinical practice guidelines, the highly successful 2019 Stop the Clot Roadshow, which received international accolades, including the prestigious World Thrombosis Day Activity of the Year, and most recently, the development and launch of a novel VTE risk assessment audit tool. To mention some of these in more detail, the development of the data dashboard was a major step towards understanding the burden of VTE and specifically hospital-acquired VTE within the Ireland East group. So this screenshot is showing some of the group level data, but every hospital within the hospital group can also access their own hospital-specific dashboard. And within the VTE working group, we can provide training and access to individuals from any of the individual Ireland East sites who may wish to access this data for their own purposes of quality improvement locally. As well as providing clinically meaningful data, this dashboard has also been the source of a number of academic outputs, including a publication in BMJ Open in 2018, where we described for the first time VTE instance data on a large scale in this country. Our latest endeavour has been the development of a novel electronic VTE risk assessment audit tool. So obviously at the core of any efforts to bring about sustained quality improvement is the requirement for continuous rolling audit and assessment of performance. And national and international guidelines recommend that compliance with VTE prevention guidelines, which includes monitoring rates of completion of VTE risk assessment, should be maintained on a rolling basis. However, we know that maintaining this process using traditional paper-based systems has been very challenging in the past. So in collaboration with MEGAP and with the support of the Ireland East Hospital Group Executive, for which we were very grateful, we developed an electronic VTE risk assessment audit tool in the form of a smartphone app, which we launched in 2020. This app is entirely paper-free, very user-friendly, and there is a central dashboard which automatically stores and collates all the submitted data in real time and generates audit reports in real time, making the entire process of maintaining this long-term continuous rolling audit system so much easier and more enjoyable than the traditional cumbersome paper-based approaches. And for users, there is very little to do other than to make a couple of clicks on their smartphone. All sites within the hospital group have access to this app free of charge. But due to COVID, the full rollout of the initiative has been a little bit delayed, but we have had very good and early engagement here in the Mater site, also in our latest hospital in Navan, and we were delighted to launch the app also in St. Vincent's Hospital and in the National Maternity Hospital recently. And now we have our sights very firmly set on completing the rollout of this audit tool to all general hospitals within the Ireland East group over the coming months. But of course, we will need a lot of support and engagement locally, and so we will be seeking out individuals and volunteers in these sites over the coming weeks to engage with us to get this off the ground and to ensure that all our patients across all the hospitals in the group can benefit from this technology. It's important to mention that we have dedicated IT support available from MEGAP to help launch the app at the individual sites. But the process is really as simple as downloading the app. We issue you with user details and then pressing start. In the various sites, we've had a mix of pharmacists, nurses, medical students, and NCHTs involved in this process of completing these audits. And I think in particular for NCHTs, we have found that this process has been a very efficient way for them to satisfy their own mandatory training requirements to be involved in audit during the course of their training. So when the Ireland East VTE committee meets again, probably in the coming weeks, we really hope that we will have a lot of engagement and crucially named individuals to act as contacts for those remaining sites where we need to get the ball rolling with the rollout of this app. We were honoured to have been recently awarded a number of awards in the inaugural VTE Thrombosis Ireland Exemplar Awards, including Best Hospital for Orlays Hospital in Navan and Best Overall Hospital Group. But as Anne-Marie will no doubt remind us shortly, if we want to keep winning awards, we're going to have to keep up these efforts. The management of VTE, as demonstrated in the cases we presented earlier, is becoming increasingly complex. And the only real way forward is an integrated collaborative model of care, bringing together all the necessary expertise in a patient-centered and equitable manner, so that no matter where or when a patient presents with complex VTE, that systems and care pathways will be in place that will guarantee a certain standard of care, similar to the models of care that we see for other cardiovascular emergencies, such as myocardial infarction. The cases presented this morning show the value of integration between haematology, acute medicine, radiology, critical care, etc. But we must also consider the very important and valuable potential contribution from other health professionals, including, of course, nursing, and in particular, the potential role for advanced nursing practice to support the expansion of VTE care in this country going forward, which I think will be vital. And so it's my pleasure now to give the final words in this presentation to Anne-Marie O'Neill. Anne-Marie is the founder and CEO of the patient advocacy group Thrombosis Ireland, which provides support and education to VTE patients and their families. And we are also honoured that Anne-Marie serves as a very valued member of the Ireland East Hospital Group VTE Committee. So thank you very much, Anne-Marie.
Thank you very much, Barry. Good morning, everybody, and thank you for the opportunity to present the future of excellent VTE patient care from the patient perspective. I'd also like to thank you as a team and a group for your continued support for VTE patient safety. Yes, Ireland East Hospital Group won 5 prizes in the VTE Exemplar Awards in 2021, but you're only as good as your last trophy. So it will be launched again in April, May this year. And so we hope that each of your hospitals will be entering in a number of different groups to show us what you're doing to improve patient safety within your own hospitals. So why are we really pushing this whole agenda of VTE and really forgetting about all of the rest of it? It's the #1 cause of preventable death in our hospitals. So we can possibly prevent some of these deaths. We've got to do something about it, and we've got to, keep the pressure on. 1 in 4 people worldwide are dying from conditions caused by thrombosis. So we can't ignore it. We've got to continue to strive to be better. So I'm going to mention the top risks again, and actually hospitalization. Barry mentioned that 60% of blood clot cases happen as a direct result of a hospital stay. That affects a large proportion of our population. Surgery, cancer, 1 in 5 cancer patients will get a blood clot, and most within 50% at least within the first 3 months of diagnosis. So we've got to tell them, we've got to communicate with them. Immobility, and that affects any of us travelers, if we're ill at home with COVID or gaming, if we're immobile in hospital 3 days or more, it's a risk factor as we get older. And personal or family history, using estrogen-based medications. And then, as our previous speakers mentioned, it is a huge issue with pregnancy and after birth. And then I'll mention also, lower limb injury and leg cast. We've got to really warn people in orthopedics as well. They're immobile and they need to be really aware of it. So how do we save lives from VTE as a team and ensure that every patient, no matter where they live or what hospital they present to, that they receive the same high standard of care and a good pathway to ensure their best outcome? I think the first thing for sure is that we need to ensure that everybody is VTE risk assessed, and that means everybody. and that we audit this regularly to ensure that it's happening, and that we collect the statistics. Because as Barry mentioned, we don't have national statistics. It's an absolute disgrace that we don't know what we're dealing with, and we need to change this. And I think Ireland East are striving and are definitely leading the way. And as a group, you're able to give us those statistics, but we still don't have national statistics. So, you know, we need to encourage all groups to do this and to follow your lead. The next thing we need to do is take time with our patients. We need to explain to them what thrombosis is, what their risk is, what the signs are to watch for, and the really important fact that they need to get medical attention fast. And this really is particularly important on discharge. I mean, they're minded within the hospital, and even if you haven't discussed it with them, you're overseeing their care, and usually they're reasonably protected. But at home, when they go home on their own, and for a further 90 days, when they're still at that increased risk of getting a blood clot by virtue of their hospital stay, they need the knowledge to protect themselves. And if we don't do it, we're responsible. So use the alert card. The HSE approved blood clot alert card is available in all the acute hospitals. If you can't find it in your hospital, contact Med Safety in the HSE or Thrombosis Ireland, and we will try and direct you to where it is in your hospital. This small little laminated card has all of the information on the signs and symptoms, the risk factors, and what a patient can do to protect themselves. And they can just keep it in their wallet and refer to it regularly. It also reminds them that 60% of clots happen in a hospital or in the 90 days following their admission to hospital. We need to talk about anticoagulation medication. I mean, this is pretty hard-hitting, serious medication, and it's really important that it's discussed with the patient which one. We've got to make sure that whatever medication we choose suits that person individually. So we've got to consider the financial implications. I mean, warfarin is cheap, but if you want to self-test, it's expensive. It's not covered on any scheme in here, this country. DOACs are much handier, but maybe they won't suit somebody that has previously suffered with heavy periods. There's certain medications that don't suit people. So that discussion has had to happen. Also, patients really need to understand what they're taking and how important it is to take it as prescribed, because as we know, particularly with the DOACs, if they don't take it properly as prescribed or double up or forget one, they're out of range and not protected. So it's really important that they understand the significance of taking it exactly as prescribed. So discussion and a little bit of education around this is really important, and, you know, straight away when it's being prescribed. We need a fast and efficient diagnosis and treatment pathway. And the only way we're going to get this is if healthcare professionals are educated. It's embedded into their early education and continued education, and that there's a constant awareness within your hospital. Because as we know, VTE presents in ways that would lead to make you think of other conditions like pulled muscles or indigestion or heart, or even liver stones. I'm looking at your man holding his arm. You know, you can get that pain in your shoulder. Headache could be migraine, concussion, whatever. So if there isn't that real embedded awareness right at the front line, you know, at triage, right through the hospital in all departments, people aren't going to have VTE in the mix and consider it and have a question mark and take action. And we need that education and awareness. Recovery. This is the missing piece of the puzzle. This is what is not happening at the moment. And to ensure the best outcome for our patients, to ensure that they're not back in your ED with a second VTE, to ensure that they're not clogging up your psychology departments and not coming in with post-thrombotic issues for years to come, we need to implement a recovery program after diagnosis. And physical recovery needs to happen straight away, practically as soon as that anticoagulation medication kicks in. We need to tell our patients that it is safe to get walking, to get moving, to push that blood through their body, because I'm telling you from personal experience, you're not inclined to do it. If you're told you have a blood clot in your body, you don't want to move, you're terrified. So if your doctor tells you that it's okay, once this medication, after a few days or a couple of weeks, this medication is now safe for you to get moving, that patient will have a better outcome for sure. They're less likely to have that post-thrombotic issues, and also their headspace is good. And then as far as the psychological recovery, if you've done what I asked and taken time to discuss the condition and to empower the patient to protect themselves, you've helped already with the psychological recovery. But there also needs to be a psychological service as part of the recovery for those that have taken it harder, that are struggling that bit more. So please consider introducing a recovery as part of your pathway for these patients. So patients have said, getting a clot was the worst part of my treatment. It was so unexpected. The urgency with which it had to be treated was terrifying. If I had known that the leg pain was so serious, I would have acted sooner. Why was I not warned about my risk? So I suppose the most important thing is that I think in order to do this, it's a big job that we need to do. But what we've learned from experience over the last few years is that we're much better if we do it together. So don't expect to do it on your own. Empower your patients to care for them with you, because together we are stronger.
So my name is Fionnuala and I'd like to conclude today's absolutely phenomenal presentation by, on behalf of all of us, thanking most sincerely Anne-Marie O'Neill for her absolutely powerful words. And once again, Anne-Marie, you've inspired me, you've inspired all of us, and you've given us a call to action. Anne-Marie is a pulmonary embolism survivor herself, and I cannot tell you how much she does to support patients in Ireland and to raise awareness, not just in Ireland, but internationally, of this very common condition that needs to be acted on quickly. Anne-Marie was awarded the World Thrombosis Day Runner-Up Ambassador of the Year 2 years ago, and has addressed the European Parliament on 2 occasions, and I'm sure you can see why. Anne-Marie, thank you. I really can't thank you enough for being with us this morning, and thank you to all our phenomenal speakers, Dr. Kevane for leading us and organising us, Professor Murphy, Professor Moriarty, and Anne-Marie. We are now joined by a stellar cast of panellists, including the Mater Hospital Chief Executive Officer, Mr. Alan Sharp, Niamh Hanlon, Chief 2 Pharmacist in Medicines Information, St. Vincent's Hospital, who you saw there in Dr. Kevane's presentation, having been awarded a Warrior Award by Thrombosis Ireland last year. Professor Owen Smith, Professor of Paediatrics, Adolescent Medicine and Haematology, and Dr. Michael O'Connor, National Clinical Advisor, Acute Hospitals, HSE. Mr. Paul Gallagher, Nursing Lead of the Ireland East Hospital Group, who has supported us over the years as well. And finally, Ms. Ciara Kirk, Clinical Lead, Medication Safety of the National QI Division, HSE, and Therese Dalchin, Amric Lead of Acute Hospitals, HSE. And for those of you that don't know, Ciara and Therese's leadership, support, dedication, and tireless warriorship for VTE in Ireland is without comparison. We couldn't do it without you. And you will have heard from Dr. Kevane's presentation of the phenomenal work that Ms. Kirk has done to lead the almost seemed like an impossible task, the VTE Collaborative several years ago now, but which is growing and has truly changed the face of VTE in Ireland. So thank you all. Without further ado, I'll hand back to our overall chair today, Dr. Tomás Breslin, to open up the Q&A.
Thank you very much. Fantastic talks, everybody. A lot to dissect there. I have a couple of comments myself, but before that, we'll just quickly get a couple of the questions from the Q&A. Can a thrombectomy be performed on chronic or more organized clots in patients with post-thrombotic syndrome, CTEPH? If yes, does clot retrieval improve symptoms in such patients? And answer from John, just for those of you who haven't seen it, patients with either CTEPH or chronic PTS in the legs should definitely be seen for potential intervention with good evidence for who can benefit from this, and the majority can be managed with minimally invasive treatments that are well tolerated. Acute symptoms and long-term morbidity can be improved. Don't know if you have any further comment on that, John, but certainly the evidence on intervention hasn't been as promising as we'd like to date, but it certainly seems to be a very valuable part of treatment, but I guess it's in a selected group of patients.
Yeah, I think that's pretty fair. And I think the main important part of this is patient selection. And so having a really good working relationship between the patient, the physicians that they're seeing every day, and then people who are involved in the VTE space, whether they're in hematology, general practice, hospital medicine, or in interventional interventions in VTE is really important, because it's not going to be for everybody, but there are people who have either high-risk features on presentation or poor outcomes later on who are definitely going to benefit. And the good news is there's a ton of new advances in either intervention or pharmacologics and different therapeutics that I think are going to be available to help these patients.
And it kind of brings us to your point, you know, congratulations on your appointment to the PERT consortium. Many people may not be aware it's a fantastic international organization which advocates for pulmonary embolism response teams. That's what PERT stands for. And the idea that there's a multidisciplinary group of people who get together on a Zoom call nowadays, usually, to focus on one particular patient. This is pretty highly evolved in a lot of North America, and usually involves hematology, emergency medicine, critical care, interventional radiology, cardiology, those sort of specialties. And definitely, you know, we all know that in any condition in medicine where you have a multidisciplinary team focusing on their care, the outcomes are going to be better for those patients. So don't know if you have any comment on that, John?
Yeah, the main comment is to say that we've seen this happen with a lot of other disease states, that things are better managed together. When we've seen STEMI teams for heart attacks, or stroke teams, trauma teams, and now tackling one of the biggest causes of death and disability with acute PE, we are putting together team-based approaches to help risk stratify these patients, appropriately triage them for their care, and then manage them in the best ways. And, you know, I'll give a plug for the PERT Consortium. It's the largest PE society in the world now. It was predominantly North American to begin with, but now with a lot of outside of the US sites. And we're proud to be involved with people in Ireland who are real experts in this field. And I'm really looking forward to expanding the role of the PE societies and PERT's consortium in particular in Ireland.
Yeah, and I know that, you know, we do have these PERT teams at local levels here, just on a sort of volunteer type basis. We don't have a formal approach, but I think that's something we need to look to. It's fantastic that there's a cross collaboration between the hospitals and IEHG with that patient that you described. So I think that's something we need to look at developing more and resourcing more. So well done, and thank you for that. So just, there's a comment: a substantial number of pregnant women need thromboprophylaxis. Can an oral anticoagulant be used postnatally for prophylaxis? How to address non-compliance related to cost? Karen, maybe?
I might take that, yeah. I mean, DOACs are contraindicated in pregnancy, and during breastfeeding, they're small molecules, they do cross the placenta. So in many ways, we're stuck with low molecular weight heparin at the moment. We do, on very rare occasions, use warfarin in the second, early third trimester in patients with metal valves. The number of metal valves we see these days is a lot lower than it was. So we are stuck with low molecular weight heparin. Having said that, in the group that we are dealing with, I'm always humbled by the compliance of the patients. It's probably because they're pregnant and caring not just for themselves, but for their fetus. There are ways to look at compliance, and in the National Maternity Hospital, we're trying to join a group that has a sharps box, for example, that clicks and monitors each time you actually get rid of your needles. So in certain subgroups of patients, it will be helpful in determining compliance. But in the main, in the pregnancy situation, it's not a huge issue for us.
Karen, just wondering if we have any comments from Michael O'Connor, Ciara, Paul on the panel.
Yeah, thanks, Tomas. And I mean, again, I spotted this symposium last evening, actually, to be honest, and then joined and then just got bumped to panelists. So thank you for that. I think the challenge that has been raised at this meeting, and in fairness, I understand that this process has been going on for quite some time, I think is a clear challenge, and it has been clearly demonstrated to us where these preventable deaths are, and obviously the treatment options as well. And that very elegant presentation by Karen and John and Barry really is a fantastic opportunity. And I think the challenge has been raised by Anne-Marie. And I'm delighted to see Therese actually on the call, because actually there are a lot of moving parts in the acute hospital sort of sector from the point of view of clinical priorities. And Therese Dalkin has been absolutely pivotal in sticking little things in my face all the time about VTE, 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 don't ignore VTE. And I'm quite frank about that, actually. And I suppose to some degree to move it on, actually, to have a standardized approach, you know, the problem is clear. The solution has also been clear. And actually what we're looking at, actually, to be honest, is having a standardized approach along the lines of what Ireland East have been doing, really, to be honest, and the very straightforward, simple things done well, day after day after day after day. So Therese really has been instrumental in pushing for a national clinical lead, which we have funding for now. And in addition to that, a project manager. And I know, I actually, to be honest, I put a lot of mass on project managers actually to take things forward. And Ciara I see Ciara there in the background, who's doing an awful lot, or has done a huge amount of work, Ciara Kirk and Philip Crowley as well. So there's a tremendous opportunity, but I don't want to make this as platitudes, really, to be honest, on a webinar today. I think the challenge has been raised by yourselves. I think Anne-Marie has spoken extremely clearly to it. Looking forward to working with Thrombosis Ireland. And I do think everybody needs to be absolutely applauded for this. And particularly want to applaud Therese, because she's working in our office, obviously, for bringing it to my attention. But I think it's a wonderful opportunity to step onwards and in addition to focus down on the things that have distracted us over the last 2 years with COVID. You know, we've all been COVID, but we're back to usual things, doing things properly. So thank you very much for the opportunity.
Thank you, Michael, and it's a pleasure to have you, and thank you for coming on board at such short notice. I don't know, Tim, if you have any...
Yeah, just maybe a comment on Michael's thank you and the talks in general. I mean, one of the things, I mean, like John Hughes keeps saying the same thing, we need to think about how we develop medicine in Ireland and where we're going with it, and with Sláinte care developing, and what do we do with groups. And I think internationally, and I think this presentation today shows it, I believe an academic health science centre model, and I'm going to expand on that in a second, is the way to go. And I think this is a brilliant example of multidisciplinary teamwork, which is a lot of hard work to do. I'm very jealous of this group, actually, from a brain neurology viewpoint. I wish we had something similar. So well done. It's very hard to do this, trying to get the moving parts to work and people to work together. It's superb. And then you bring into that your teaching, training, research, innovation, which is a lovely example of it. And Barry's slide sort of touched upon that. I probably would add a bit to Barry's slide. I'd put the university in the middle here as well, because the molecular biology and the new things that are going on, thrombosis and Philip's work is important, that would feed new ideas, new therapies. And John's work as regards innovation and work with regards intervention is going to be important. So that feeding back and forth between the clinical service and the university and the hospital, the academics, is key. And then I think the other thing, Anne-Marie's points then expands my comment, which I think rather than an academic health science centre, I've been harping on about an academic health science system, which I think Anne-Marie captured that. What are we going to do in the community here, and how do we prevent thrombosis and clots? And that brings that component in, because you've got to bring that education understanding out both to patients, but also the other GPs and primary health cares. So you end up with that sort of integrated model, prevention of disease as much as possible, but that you've got the expertise, the knowledge base, and the science that drives your new therapeutics to it. So this is a really excellent example of what we should do with Irish healthcare. It is a big message, maybe from Anne-Marie's viewpoint, then to our politicians, who particularly have been waving papers as regards Sláinte care. I get that, but how are you going to implement Sláinte care? How do we do that? How do we get the care out in the community? And I can only see this model as the only way I personally think it's going to work. Even an acute hospital, like Alan's here on the thing with the matter, driving that innovation, linking out to the GPs, community primary health care, and then lifting teaching, training, research, innovation, retaining, recruiting better staff, and then suddenly you end up overall. Like this is a wonderful example of how care is improving in this fashion. So I think there's a big message in this talk. Yes, for thrombosis, beyond that for Irish medicine. So on that note, I'll move on.
Thank you. Any of the other panelists want to come in on the discussion?
So Tomas, I would love to invite, so I know that Ciara, Kirk and Therese, as you know, as Mike has so elegantly highlighted, have done phenomenal work in this area over the years, and I'd love to ask Ciara to just give an overview of the challenges that have been faced and what has been done at an organisational and national level under her and Philip's leadership. Thanks, Ciara.
Sure, yeah, and I think what's important as well is to share that there are a lot of resources there. So if people are watching this and wondering how do you get to really good prevention, particularly, so we particularly focused on prevention and on information. So on SaferMed, so I highlighted, Anne-Marie mentioned the patient alert cards. So that means that people who are particularly high risk, obviously Niamh O'Hanlon holding one up there. So Anne-Marie and Thrombosis Ireland developed the material and we worked with them, and we've recently just done another large print run. So we have lots of boxes of patient alert cards in my office at the moment. So we're really happy to send them out to anyone. So email safermeds@hse.ie if you would like a box or more than a box of them. And that's so that people who are higher risk recognize it if it happens, and it's the first step to early and effective treatment. The main focus of our work and the improvement collaborative was mentioned. That collaborative showed that it is very, very possible to improve the appropriateness of prevention. So the appropriate prevention, appropriate prophylaxis is the goal. If you're measuring other goals, remember that it's the appropriateness of prevention that is your actual goals. You must make sure that that is being achieved, whether that's including risk assessment or not, but the goal you're really interested in is everybody getting the right prevention for them and for their risk. And the tools to do that we have now, as a result of COVID, really, we came together. So we now have national guidance and a national protocol to use. And that should be in place. I know in some places it's been adapted, but that's available to across the country for medical patients and people with COVID. The information from the collaborative is also available as a report, which is on safermeds.ie. And really for anybody who's trying to improve prevention of VTE, that's a must read and must follow on the tools. I would say that since I wrote the report, but there really is so much in there. So you're learning then from 27 hospitals who tried to do something about it, and in most cases managed to actually really shift the appropriateness. Overall, the appropriateness increased by 1/3. It's really substantial improvement, even with all of the challenges. The measurements, so the KPI, maybe I'll let Therese respond to the information about the measurement in the KPI. Therese, will I pass over to you?
Well, yeah, I mean, thanks, Karen, and thanks, Mike, for your kind words. I mean, I don't think I've done that much, just nag a lot, but yeah, I suppose absolutely. Ciara and I have worked hand in glove together between the quality arm of acute and acute operations to try and help to drive a national initiative that will support the type of stellar work that you're doing within Ireland East, as you say, to scale it up on a national level. So I suppose a key component of that was to establish a national KPI, which we did. It's about 3 years now in existence, and it's very important when you want to bring some attention to something that that there's a measurement that we can benchmark hospitals across, and that we can do comparisons and drive the agenda around resourcing a solution. So in that vein, we established a KPI which we called hospital associated, not necessarily hospital acquired, because we know it's hard to be accurate about that, VTE, which is now a standard KPI across all of the hospitals, the acute hospitals. We have quarterly reports that come that are available to me every 3 months. I issue them to all the hospitals, and it's been driving improvement groups like yours in other hospital groups like South West and Dublin Midlands in particular. The KPI did include patients who were readmitted with a VTE, which caused a bit of a delay in it. So there's been a significant change this year in the service plans. The KPI now excludes the patients who are readmitted because the numbers were very small. And it allows us to have monthly reporting. So from this year on, we will, from March, I suppose we'll have it from January, it'll be January data reports in March. We will have monthly rates of hospital-acquired VTE in all hospitals. Now that, as you know, is included in the hospital safety statement every month, which again gives it a lot of attention. And we analyse the information that we get with the support of Fionnuala and 2 other consultants, Mike Watts and Dennis O'Keefe in Limerick, who've also been very supportive to us nationally, to look at trends and to try and issue information around the trends. But I suppose what we haven't got to yet is having a group of experts that can really look at the trends, and we have seen obviously changes in those trends associated possibly with the COVID waves, whether it's indirect or direct, we're not sure yet. But we hope with the addition of a clinical lead and a program manager, we will have a more coordinated approach to improvement in terms of that performance. So I think that covers it generally, Ciara. And thanks for the opportunity this morning to join you. It's been very interesting.
Thanks very much, Therese. I guess, as a clinician, when you look at the statistics from the UK about the reduction in mortality from VTE, from just simple prophylaxis, administering prophylaxis appropriately, like if that was a new drug or a new device, people would be saying, oh, you must have this, everybody must get this treatment. And really, it's prophylaxis, it's not sexy, it's prophylactic dose, low molecular weight heparin, but it's something that needs to be done and done well. And it is a challenge for us with our IT systems. We don't have electronic prescribing, which is, I think, probably one of the major barriers to not having a standardized risk assessment done across the board. But until such a time as we do, I think we all need as clinicians to ask the question, are we preventing this disease appropriately in our hospitalized patients? Are we risk assessing everybody? Are we prescribing appropriately? We have a lot of work done around hospital-acquired infection, and to date, we don't have as much done around hospital-acquired thrombosis, but thanks to all your work, we're pushing in that direction. So my only other comment, just to pick up on what Anne-Marie had said about, patients and the trauma of a diagnosis of VTE, I think there's also scope for improvement here. And again, from my own specialty, emergency medicine, and our, hospital physicians who diagnose DVT and PE, I think there is a piece of work to be done on improving the communication and what we say to patients and how we communicate risk. And in fact, the majority of patients, or a lot of patients who are diagnosed with DVT and PE, once they're on treatment, their actually risk of a bad outcome is actually very low. And I think sometimes we don't communicate this as well as we should. So that's my comments. Anything further?
Yep, I'd like to thank everybody. I have to say I'm absolutely delighted to hear the funding is there for the clinical lead and a program manager. I know from my experience of working with Ciara and Therese on the blood clot alert card, and talking to people on the ground about the distribution and how they use them and where they're used and whatever, that there's a real need for a boss. There's a real need for somebody to actually say how this should be done, who should be doing it. And we're wasting time not instructing this. So there's a lot of chaos. We're doing really well. We are getting awareness out there, but it's in an ad hoc way. And so there's a real need for an exact way and a boss to lead it. So I'm absolutely thrilled. I'm in the best form now. I'm going to have the greatest weekend, I'll tell you, because I didn't realize the funding was there. I'm so delighted. So like, I want to thank each and every one of you, because I know each and every one of you in your own way has taken a piece of this work and tried to make it happen. And it's crucially important for the patients, crucially important. And for the newer diagnosed VTE patients, hopefully they'll have a better experience and a better outcome than our previous patients. So I'm absolutely thrilled. Thank you.
I think Barry and Karen have your hands up. Thank you, Anne-Marie. As always, Anne-Marie, thank you for your inspiring comments and
also might just make a comment, and I'm going to be a caricature of my usual pragmatic self. This isn't rocket science, as somebody has said. The problem is obvious and the solution is obvious. And you've seen our wonderful local pharmacist wave a VTE card in front of you. Can you imagine if you had a dedicated thrombosis pharmacist in every hospital with an AMP? That's all you need. The problem is when somebody, as Anne-Marie has just said, when somebody owns the problem, the solution is there. So it's very straightforward, and the clinical lead piece is a huge piece of this. But the opportunity to say with people on the call this morning that the resourcing at a local level is really important, just in terms of AMPs and pharmacists. The medics are there, really. We could have that conversation separately, but it's having the warriors on the ground that makes a difference.
Thank you, Karen. The local champions.
Thanks, Thomas. I think me and Karen are probably thinking along the same lines. Because I suppose the only comment I was going to make was that from our perspective, we really don't want to neglect the potential role for nursing to support the expansion of VTE care, because we've seen in other countries that's been absolutely vital. And I know Paul Gallagher, who's the director of nursing for R&D, is on the call as well this morning. Thanks, Paul, for joining. I just wonder, Paul, maybe do you have thoughts, in a way that we can support nursing and expand VTE care with nursing support? I think is crucial.
Yeah. Thank you, Barry. Can everybody hear me okay?
Perfectly, thanks.
There's an extremely important document being launched probably early next week, and it's probably the first of its kind in the last nearly 20 years plus for nursing and midwifery, for nursing midwifery leadership. And it's based on a report of what's called the Expert Review Body for Nursing and Midwifery. And whilst there are a number of recommendations in it, there's one particular recommendation that I have in draft format. And there's no surprises when it says that the importance, or it refers to the importance of advanced practice. And that's at clinical nurse specialist and advanced nurse practitioner level. And thanks to Karen and to Barry for mentioning nursing already throughout, and others for mentioning nursing. And I mean, it's very clear that there's a requirement to align, I suppose, the acute hospital care to the enhanced community care program, or programs, should I say. And Mike, you'd be very familiar with this. And this is another example where there's an essential service in the system, or a service need, both at the acute hospital level, and as Anne-Marie has referred to, how people are supported outside of the hospital. And again, Karen saying you're taking a very pragmatic approach. It's about getting people in, yet we don't have the funding for it. So I think there's this document that's going to be hopefully launched early next week by the Minister, will provide an opportunity perhaps to shake the cage a little bit clearly and maybe more robustly for VTE in the system. And whilst there are many examples of service needs that require advanced practice, I think this is absolutely essential that we all perhaps work together on this one. It's not going to be easy. There are limited funds available. And Mike, if you have any influence at all, and your colleagues at HSE level, to influence this, because I think the investment for nursing at VTE and advanced practice level has been little or none, very little in fact. And I think this is a huge opportunity for us all to pull together. And with perhaps the governance group, Barry and Fionnuala, that we have at Ireland East is probably a starting point, perhaps, to see how we can move that. I will put the challenge to myself and indeed Alan, and if Mary Raftery, the Director of Nursing from the Matter, was on, perhaps we need to look at ways whereby we need to look at whatever resources are available at local level and converting those resources into advanced practice, or at least contributing to them. So look, there are huge opportunities here. It's not rocket science, as Karen said, but there's great opportunities. And I think the governance group that we have in Ireland East should drive that. Thanks, Barry.
Thanks, Paul. I think Alan has your hand as well.
Thank you, Barry. Just first, I'd like to thank IEHG for the invite for today. It's been very enlightening and great to see fantastic work being done across the system to try and improve current standards. I'd like to thank Anne-Marie as well for her insight as a patient. It's fantastic to hear that. It's also great to know that there's money being invested in a program manager. So really well done to everybody for advancing it. I just want to kind of bring something back to numbers, and I just as Karen mentioned, 2 resources going into each institution. I just did, calculation on a piece of paper, and for the whole hospital network system, you'd be looking at about 4 or 5 million. Now, it sounds like a big number, but it really only has to save something like 13 beds in the whole system to actually recover its own cost, and that's a 0.1% improved turnover of beds. So if we can reduce bed days consumed by patients with VTE by a very small amount across the entire system, you get that fantastic patient from that small investment. So I think I know, like, we're all about patients. It's all about getting the care, making the outcome for the patient as best as possible. But sometimes when you boil it down to the numbers, you see the benefit is huge for such a small investment. Now, it looks big, but in the overall scheme of the system, it's not that big. It's just a comment I'd like to make.
Thanks, Alan. CEO of the matter. Anybody else? Any other comments? We're coming towards we've gone slightly over time. If there's no further comments, I'd just like to say thank you to everybody for a fantastic presentation. Thank you particularly to HSE and management people who've joined the meeting this morning. This is probably the first time we've had such a fantastic array of people, from Anne-Marie as the patient, from the clinicians treating the patients, to the people in the offices that we don't see who are also advocating for this, and getting everybody together. I think Anne-Marie's last slide with the hands all getting in together, I think that's how we really make changes. We can all bang on in our own silos and in our own offices, but unless we're getting together like this and talking about it together, we're not going to affect real change. So it's quite exciting that we've had such a forum this morning, and that there's a consensus that this condition needs to be better recognized and requires more resource. So thank you very much to everybody. Well done.
Thank you.